Well, hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I am your host, Shawn Needham, along with my wonderful wife, Janet, and you can catch us every Monday, 1 to 2 p.m. Pacific Standard Time, right here on my personal Facebook page and the Moses Lake Professional Pharmacy YouTube site. And a few days later, you can also catch the episode on most of the podcast forums, so iTunes, Google Play, SoundCloud, and so on. So go to those forums and subscribe to them and don't miss our podcast. And especially go to our YouTube channel. Our YouTube channel is growing all the time. Subscribe to our YouTube channel and comment, please. Let us know what you like about the episode or don't like, and if you'd like future episodes. So the Moses Lake Professional Pharmacy YouTube site, please go there and subscribe. Today, I would like to welcome Dr. Cristin Dickerson. She is the head of Green Imaging, which is an imaging center that has expanded. I think their main location is in Texas, but they're expanding all over the nation now. And I'm really, really super excited because it is bringing affordable imaging to a place near you soon. Let's hope. And why is that necessary? Because, as she will probably explain a little bit later, sometimes we worry about the price of imaging because it's so costly, but it doesn't have to be. I know there are examples of MRIs being $3,000. Yet, if you go to a place that, like Dr. Dickerson's clinic, you can get an MRI for under $500. And I'm sure that Dr. Dickerson is going to explain some of those things with pricing. So, without further ado, Dr. Dickerson, welcome to our show.
Thanks so much for having me. Thrilled to be here.
Yeah. So tell us a little bit about your history and where you went to medical school, and then, where you practiced before then, and then, why you decided to open Green Imaging.
Okay. Well, I'm a Houstonian. I'm a Texan, and I did train here in Houston at University of Texas, and spent a large part of my training at MD Anderson Cancer Center, and that was quite formative in my career. And I started out in a multi-specialty group, which is a really wonderful, it's an old-fashioned way to practice, but it's a really wonderful concept. And it's kind of what we're trying to do now with narrow networks and more telehealth and, pulling doctors together where, we sat down for lunch every day and talked about patients and consulted on patients. And that was just a great way to practice. And I actually went to work for this multi-specialty group because I didn't want to get into the business of healthcare. And I had been practicing, maybe 2 years, and we had a new business office director, and she came in with this big box of what we called yellow tickets. And they were from the work we did nights and weekends over at the hospital, on call. And it turned out the hospital wasn't giving us the demographic information and the coding information we needed to bill for literally millions of dollars of care. And so I decided I had to get into the business of healthcare. Right. And within a couple of years I was on the board and then ultimately was the president of the clinic. And it was a great MBA. I had a CEO and a CFO, and I give them tremendous credit for teaching me a lot of the business of medicine, but also for their innovation. We had a CEO, Dorma Kohler, who got the great idea. This is when premiums were skyrocketing with the BUCA plans. That's the Blue Cross Blue Shield, United, Cigna, and Aetna, for those who I know you all know, but in the traditional healthcare plans, and deductibles were skyrocketing, premiums were skyrocketing. And so we started pulling everything we could out of that plan. And, either providing the care at zero out of pocket for our employees or with some strategic partners, down the hall in the same building. And we started carving out parts of care and making it, number one, more affordable for the employees, but number two, holding those premiums down so that, so that they could afford healthcare and we could afford to help them pay for it. So that was my venture into being a self-funded employer. So that's been in the back of my brain for a long time. I went on to work at ultimately the imaging, through a hospital system acquisition. Imaging went away for this multi-specialty group. So I moved to another multi-specialty group and really just started doing green imaging full-time in February of this year. So I had done this on the side for 7-8 years. But I always, saw the opportunity for this self-pay network that I was building in Texas to become a preferred network for employers. And, that has come to fruition the last 4 or 5 years. We've really been working, what we saw was we could get to a lot more patients and create huge savings, at multiple levels, not only for the employees, but for the employers. And sometimes, as in our biggest client, the tax base. Our largest client is a school district in Florida, and we're going to save them $1.5 million this year. So, that's a great story. And we're able, we still, a third of our patients are still self-pay. And some of those are through health sharing ministries and other vehicles where they present as a self-pay patient. But really, we're able to reach so many more people by doing direct contracting with TPAs, cost containment companies, directly with employers, all kinds of benefit cards. There's so many different creative ways people are trying to solve the healthcare conundrum, and they're effectively doing it. And we love being part of that.
Yeah, that's great. I'm glad you're part of this revolution. I believe that the future of healthcare is going to be up to doctors like yourself, kind of getting away from the traditional system a little bit and thinking of some innovative ideas. I mean, we can't expect the federal government to solve the problem. I think the federal government kind of caused the problem. So physicians really need to take back healthcare, and thank you for doing that, Dr. Dickerson.
Oh, it's really exciting.
So I kind of just let's get, just if you don't mind, we'll just get into some pricing. And so for instance, my son, he broke his left tibia, compound fracture, back in May, and we didn't have much of a choice, had to take him to a local hospital here, and the x-ray was $424. So can you explain? Yeah, you're laughing. So why are you laughing?
I've actually seen worse here at Texas Children's Hospital on a United Healthcare plan. It's about $900 for one view, and that doesn't include the interpretation. And yet we have places we can, across the country, we can do them for $50. Healthcare is, I believe in free market principles. The center that is in the nicest part of town and is paying, rent in a very expensive rent in a big office building is very different than an imaging center in a strip center, in the suburbs. That's just a different market. And so, number one, I think, based on geography, that market force is huge in healthcare. Number two, let's look at the equipment. Is it older equipment? Can it stitch, like on a scoliosis survey, can it stitch the images together of the cervical spine, thoracic spine, and lumbar spine so they look like one big image? Is that capability there? There are all kinds of factors like that's a very expensive machine. Most imaging centers can't afford that. And so if you're putting in that kind of equipment, in the traditional healthcare system, a 3T MRI and a 0.25 Tesla MRI, on an old open magnet, they pay the same through most healthcare plans. And there's no quality, I don't care if it's a Mass General trained radiologist or a foreign medical graduate. All those things are not factored into the economics of medical imaging. And the other big factor in the economics of medical imaging, number one, like you point out, a hospital. The cost of care in a hospital system is going to be about 3 times that with an independent doctor all the way through the episode of care. And that's, we see markets where it's much greater than that. Supposedly in Pittsburgh, because of the hospital system domination, it can be 9 to 13 times higher. Certainly, in Boston, you don't even really have the non-hospital based option. Like 90% of imaging is done at Mass General or Boston Children's. And the few centers that are independent have to replicate those protocols. And so it's like twice the time on the MRI machine. And so, those are huge market forces. And so I believe in I let my imaging centers set their own prices. They know what that time on the table costs. I don't. I know a lot because I own one MRI center. I know some of their pain points. I know that helium has doubled in price this year. So I know some of those factors, but I don't know their rent. I don't know what they pay their radiologists. I don't know anything, about that center. I do know, I look at the quality standards, but I don't know their market forces. And so we do let the imaging centers, set their own prices because we believe very much that the market forces need to matter. And that's one of the things that's kind of destroyed healthcare.
I could not agree more. Free market is what is going to solve our healthcare problems for sure, and let people let you as a doctor and this podcast and other forums educate and empower individuals that they need to take charge of this themselves, because they're not being looked out for by their health insurance company. Their health
No.
insurance company does not care
No.
whatsoever. You know, in fact, when it comes to their health insurance company, all they care about is their own bottom line. And I'm a capitalist, I get that, but I just want to make people be aware that there are other options. And if you can explain that, so let's say patient has Premier Blue Cross or one of the ones that you're talking about, and they say that their preferred providers is imaging company XYZ, and they know that the MRI is $3,000 there. Does the patient have a choice to go somewhere else?
Absolutely. And I have seen doctors tell them otherwise, but that's actually illegal. And so, there are a couple of legal factors here. Number one is you do have the right. Now, some doctors say they'll fire the patient. I've seen MD Anderson do some heavy-handed. Now, recently, I've been getting letters from MD Anderson that say this patient has been given a waiver based on financial need, and we need this and this and this from Green Imaging. I love that. That's perfect.
Dr. Dickerson, can you explain MD Anderson? I'm not familiar, and I don't know if our listeners or viewers are either.
MD Anderson Cancer Center. It's one of the premier cancer centers in the world here in the Texas Medical Center, and so they've their exams, I would say, for an MRI typically in the $6,000 range.
And your price?
We can do that exam without and with contrast for $425 at our imaging center. If it's without contrast, like a knee or shoulder, we have options in the $250 to $400, $450 range all over Houston and all over the country, really. Our most expensive prices are either in rural hospital sites, where there's no imaging center, like in rural Virginia. And then in the big Boston is a tough one for us. I think our non-contrast MRI is probably $775 or something like that. But it's still a third the cost it is in the hospital.
Right. And still a far cry from the $6,000
right.
that it is in that MD Anderson. So can you explain it? Explain to our listeners and viewers how that can happen. Because I don't think there's any other industry where even look at a car, for instance, that does the exact same thing. I don't think that the pricing there's that far apart. I guess you could argue that there could be with some top end cars, but in general, this is the same equipment with the same doctors, and you got a tenfold difference. Can you explain how that happens?
One of the factors is it's market forces. The hospital systems, have, especially the really the ones that have great reputations, are able to. What's happened in Houston is several times, the BUCA plans have dropped Memorial Hermann or a Methodist or Texas Children's or MD Anderson. And, that creates a huge market force. Members really want those hospitals in the system, and then they have to go back and renegotiate those. I think MD Anderson and Texas Children's, last I heard, are only with a couple of the BUCAs now because there's such a pricing differential. But that's an okay thing in our market where we have multiple great hospital systems. In settings where there's only one hospital system, what is the insurance company to do? And, and especially when there are no independent imaging centers. The other thing is that independent imaging centers have really taken a bloodbath. Part of it was on their own. There was a lot of out of network billing that was egregious. So to pull that back in, there was a real downward, and I think that that's also why there was some egregious out-of-network billing, was that the reimbursement rates for the outpatient imaging centers were so low. But that's been a real struggle. The viability of those centers is huge. But there is really no correlation, or maybe an inverse correlation, between quality and price of care and imaging. And one of the places we see that are in hospitals that don't have the reputation of the great ones. And even in that setting, they're getting, there's some hospitals I've never laid eyes on in Houston that are some of the, highest, have some of the highest prices for imaging in the nation, actually. So there's no rhyme or reason. Their administrative costs are much higher. I will say there should be a price differential. They're 24/7. They have to have techs on call, or on site all night. Their equipment goes through. You're seeing a lot more patients, and there's more wear and tear on your equipment. You have to, you're having to deal with patients who have all kinds of oxygen and all kinds of extra equipment around them. So the throughput is slowed down by that. You have a lot of elderly patients. There definitely should be a differential in reimbursement between a hospital and an outpatient center, but 10, 20 times is ridiculous.
Right. Yeah. Janet, do you have any questions for Dr. Dickerson?
Well, I'm curious as to how your patients are able to work around you must go to this clinic or you must go to this place, because we see that in our community where clinics are really protective of their own resources. And so if you want to go outside of their system, it's very challenging. So how do you work around that with your clients, and how do they get into seeing someone like you that is making it affordable and easy access for them?
There are a number of ways we accomplish that. With the self-pay patient, it's just financial. And literally a lot of the hospital systems here know about us, and they will, if the patient can't make their patient responsibility, they'll refer them our way, which is really great. But in an employer plan, we have the opportunity to educate. And so number one, I love it when an employer rolls us in, not at re-enrollment, but just mid-year as a benefit. Look, we're going to do this for you. And that's what School District of Osceola County in Florida did. Their Cigna premiums wiped out the employees' pay raise. And so the teachers union got involved. And so they moved their near site clinic out of a hospital system, which is not a very good place to have your near site clinic. They moved it out to the Rosen Health Center at zero out of pocket to the employees, and then gave them, this imaging opportunity at zero out of pocket. And so we, did initial employee training, whether that's videos, they did a mailer. We have, posters that they put up to educate the employees. And then we do a newsletter monthly that not only has a timely topic, like right now, it's going to be about, what happens if you go without your cancer screening studies. It has, an eye-catching topic, but it also step by step talks them through using green imaging. And, the incentives are tremendously important. We had a TPA that put a $375 copay in place. Well, that's not a copay because most of our exams don't cost $375. That's a maximum out of pocket. And the education was almost impossible in that setting. That's actually the only plan we have terminated. It just made absolutely no sense. And they couldn't even get the claims. They couldn't get the EOBs to work. They had no idea how to handle that. So that was a disaster. But when it's well done, it's zero out of pocket. We have some that do shared savings, defined benefit plans. If you come in, I love that concept, because if you say you have a $500 benefit for your MRI, if you go down the hall at the hospital and spend $1,300, you're going to pay the extra $800. If you go to affordable MRI and have it for $250, you're going to keep that extra $250. And I think that's a great way to drive consumerism.
Because what needs to happen is patients need to be made, like they do in any other industry, they need to be made to shop around for healthcare. Instead of just going to somewhere where they're told to go and then, let the numbers fall where they may. They need to be incentivized financially. And maybe that can be that they get something back, or they don't have to pay as much. Either way, but consumers need to start shopping for their own healthcare, and that's what's going to make the free market work.
Yeah, and I do think that they have to find trusted partners, because when people are in healthcare stress, it's difficult to try something new. And so that's why we really believe all mammographic services, all breast imaging services should be at zero out of pocket. One of the things that was the fallacy of the MEC, the minimal essential coverage plan, was that it covered screening mammography, but not diagnostic mammography. And so, women with no symptoms were getting their mammograms free, while the woman with a new breast lump, is having to pay for a diagnostic mammogram, which is even more expensive, and an ultrasound typically. And so, that didn't work, and it led to a lot of gaming the system, and patients would try to have a screening mammogram when they were symptomatic, and it would delay care. and cost more down the line. And so, there are things, if you cover that breast imaging at zero out of pocket, which there is, if you're an employer, it absolutely should be covered, or even a health plan, because that's, we've got to get out of this mentality that healthcare is a year to year thing. We're going to cover you for this year. We have to get to plans that are, that are covering, that are promoting your health. And, especially with employers, the whole idea of employer-based healthcare is to take great care of your workforce. So in that setting, breast imaging needs to be at zero out of pocket. If a woman waits, it's 18 months, and that's an important number to know right now during COVID. That can be an upstaging in the breast cancer. So that extra 6 months can add a stage. Well, a stage in breast cancer therapy can be a very invasive difference, time off work, disruption to the workplace, having that person out. A lot of women who have more aggressive cancers are younger. So, that can be a very disruptive thing that not just the cost of that mammogram has to be factored in, the cost of care all the way down the line has to be factored in. And so when women use us in a relatively low stress situation like mammography, they're more likely to use us or get their family to use us in a higher stress situation. They already know how to do it.
Well, that's one of the things I think, that's why we had you on too. And thank you for doing that, educating our viewers, because I think sometimes those of us that work in healthcare, we take these things for granted because we just have the networks and we just know about it. But that's why it's so important for us to, educate the patients that, the right avenues to travel down. So you kind of mentioned it a little bit. You started talking about it while we're on the subject. So cancer screenings, you said that COVID has really messed up some cancer screenings. Can you expand on that a little bit?
Yeah, I can. We were down to about 50% volume, mammography even less. It was lower than that from them here in Texas, at least, and it was pretty much reflected. We read at centers, nationally, pretty much reflected across the board. We were at 50% capacity from maybe late March to June, to early June. And so all those people didn't have their mammograms, and then they started trickling back. And now what we have is nobody can get in for a mammogram until right now, early December. We see the dates, inching out further and further because there's such this backlog. And the other problem is, they're trying to stretch appointment times further apart to clean the room, keep patients from overlapping. And so that's compounding the problem. I know centers are adding a second tech, but you still have to disinfect the room between patients. There's so many factors there, but people who now think that they can go get their mammogram next week are in for a little bit of a surprise. And they can't. And, that it's very upsetting to people. They've already put it off, and, we're going to, I heard that, cancer diagnoses are down over 50% this year, which means that these are going undetected and they will be found at a later stage later. They think there may be a 4-year drop in life expectancy in the United States due to the decreased screening. I mean, that's huge.
Wow.
Yeah, I can tell you from the perspective of hearing clients, it's very hard because, first of all, they're afraid to come in, and now that things are sort of opening in some states, our state, I don't know, we're kind of back and forth, but it is a mixed message. And it is very concerning to me because even the clients that should be seen for cardiac and all these other things are holding off. So the message that I'm hearing loud and clear from you is, if you need to be screened, make that appointment now.
Right. Oh, definitely.
Get on the list. And what other things could you suggest to our clients so that they are a little proactive about it? Because I think what I hear is, well, at least in Washington State, is, if you even have a sniffle, then you can't even walk through the door. So, I mean, throw some good tips out there for your clients to get in and be taken care of?
Well, you do want to make sure that safety precautions are being taken. Believe me, the viability of these imaging centers is based on their keeping them safe for immunosuppressed patients, patients who need screening, patients who need acute care. Everyone's being very creative in how they're doing this. So I wouldn't worry so much about that. I would kind of ask about, are there multiple people in the waiting room? Some centers can't get around that. Depends on where you live. In Houston in the summer, you can't wait in your car till it's time.
No.
I'm sure with you all in the winter, you can't. So,
Right.
there are those limitations. Is there a lobby further away where I can wait? There's some creative ways people are working those things out. I would do everything to minimize the overlap. I mean, I had blood drawn today and for an insurance physical, and the guy came to my house and I kept backing away. You keep that 6 feet, you do all those things that you can. A mammogram, you should not be within 6 feet of the technologist for more than a couple of minutes. So, that risk is low. You want to make sure that you're not sitting in a room with, other people closer than that. I would ask those questions when I booked a mammogram. I would have no hesitation to do that, but know that they are taking all the precautions they can. Some exams like echocardiography. I know of somebody who was exposed to a tech who had COVID recently. And, that's a tough one because the ultrasound tech is usually right next, arm's length of the patient for quite a while. So, you do need to take an X-ray should not be a problem. A CT should not be a problem. An MRI, you really, you're a few minutes, with the technician, but then you're in separate rooms for most of it. So all of those things, you have to take the test, keep the test in mind, and then you have to weigh the risk versus the benefit. The risks are really still pretty low of dying of COVID, but we know that if you get it, depending on your risk factors and sometimes not depending on your risk factors, there can be long-term repercussions. So, I think, sometimes pull your doctor in and say, what is my risk of breast cancer? I have, 2 relatives on my father's side who've had it. Well, that's not going to increase your risk much. But if it's 2 relatives on your mother's side, you may want to be more aggressive about that. So I think that's where your doctor can help you significantly. And most doctors are doing telemedicine visits, and I wouldn't hesitate to have that conversation right now.
So while we're on the topic of that, you kind of already explained a little bit of it, but mammograms are very important, and maybe some people are a little bit confused about when they should and how often they should. So while we're on the topic, go ahead and tell us with your expertise who should get a mammogram and how often, and what are your suggestions?
I believe in annual, especially, this kind of goes against what some of the recommendations are, but I believe in annual mammography, especially when women are younger, from 40 on, because it's a more aggressive disease in that population, typically. And in older women, you've got to, start thinking about, okay, what's my longevity? My mom is 82. She has had breast cancer. She had a lumpectomy and some radiation therapy, and she's been just fine for 10 years, but does she need to be going into the imaging center, right now? Probably not. She's not on hormones anymore. She's taken the tamoxifen. She's done all of that. I think to her, that risk would be greater. Me, I need to get in there and get my mammogram. I have that family history, and, I don't have other health risks, and I need to be getting in there and doing that. So, it is a very personal decision right now, but in general, it should be annual until you feel like your 5-year longevity is no longer there. There are some suggestions that older women can, wait 18 months to 24 months. That's probably very reasonable, especially if you're not on hormones and if you don't have a family history. So, but once again, I think, your individual doctor is your best resource for looking at your personal risks and making that decision.
Awesome. Thank you for that educational piece. So I noticed your clinics are branching out, and I noticed we live in Washington, and I noticed you don't have any clinics in Washington State. Can you explain why?
Yes, because the doctors there have done a great job of keeping their reimbursement up from the traditional payers. It's very interesting. And, what we've done is we've quit going in and building out our network until we have a large number of covered lives in an area, because we're much more able to, it's not worth, these imaging centers sign, lots and lots of contracts, and many of them, they never receive a patient. So they're reluctant to just, take on a new contract that with no promised lives. If we say we have a school district down the street, and with a school district everybody lives right there, that's a game changer for them, and we can get great pricing. We are actually talking to a provider in Washington State right now. So, I think in January we have a big meeting. They've sent us some data. They're very interested and talking to us, and they're interested actually in the way we practice radiology. They said that their radiologists, are not hands-on. They're not willing to protocol exams. They're not willing to have discussions with patients. And so, this could be a great partnership. So we're very interested in that possibility.
That's exciting. So tell us a little bit about certificate of need. I know sometimes with MRIs, that's an issue coming into certain states. Can you educate our viewers on that?
Yes. Certificate of need laws are basically a way that legislators have, I think, gotten very nice meals and other things out of people who want to build imaging centers or hospitals. And it states that, you have to have a certain patient density or, population. You can only have this many imaging centers in that, unless you show some other specific need for it. So there are exceptions out there, but independent centers have not been able to compete well with hospital systems for getting these certificates of need. I know of a physician, I think he ended up on building outside the North Carolina state border, for his patients to be able to go to this imaging center so he could get around the certificate of need. So, there are ways people are doing it, but they require it. And sometimes, affordable imaging requires a drive. That's not, we employers will incentivize, give a gas card for employees if it's going to take a little bit of a commute for them to get to a lower cost center. But the certificates of need, I know that when you talk about COVID in New York, there was an issue with, hospital bed availability related to certificates of need. They are a way to decrease basically the free market, to stifle the free market and keep doctors from being able to, open up. And in this case, these were doctors who were trying to get these certificates of need in North Carolina and keep them from being able to do that. And, once again, that's just it's not in the interest of good healthcare for the populace.
Well, right. And then the patients end up suffering because when they need affordable imaging or, whatever the certificate of need is not allowing them to come in, access is actually decreased.
Right.
Well, I think too, for our consumers or our watchers, our viewers today, a certificate of need can also mean that you can't open a facility or you can't purchase equipment, correct?
Right.
So that being said, somebody else either has taken that certificate of need, and it could be somebody local, or just because it's not deemed important enough to issue it to somebody. So really you have somebody that's in control, not the consumer, not the provider. It's somebody outside of the area looking at this saying, no, or yes.
Right.
Correct.
It's basically politicians creating monopolies is really what it amounts to. Correct?
Correct. Or as Carl Schuessler would say, the cartel.
Yeah,
well,
it is.
Right, because, it's interesting to me that, we make this idea that monopolies are un-American and should be driven out, yet we are creating them legally, per se, from a legislative point of view that, only this person can practice here and you can't.
Absolutely. And, we have them in the pharmaceutical industry, as you know, the hospital systems and the insurance companies. They're all That's the cartel. And if you read the definition of a cartel, they meet it.
Yeah. And it's interesting that, all three of those, they're all three in bed together. I mean,
yes.
big pharma, insurance companies, and hospitals are all in it together. And they love their system. And if you talk to somebody that's, in hospital administration or something like that, they'll even probably admit to you privately that it's a racket. They realize it, but that's how they've survived.
Yeah, it's intentionally broken. And an example of that is when we did the claims data for School District of Osceola County, who was with, in a BUCA TPA, self-funded, but in a BUCA TPA, we found all these hospital procedure codes that didn't have CPT codes. And typically with this carrier, you can only use those hospital revenue codes if you if it's an inpatient. But there were 600 of them for imaging, for CT and MRI alone. That's wow. Way too many for inpatient. And so we started doing some digging, and they were paid out between $800 and $40,000 for these exams. And so, I was talking to, HR department at some big company, and the guy goes, "Oh, this is what happens." He said, "Here's the backstory on that. When the insurance company and the hospital system go to negotiate deeper discounts, their claims edits that happen, that their claims, things that get let up from the claims review, such that these claims go through, and that makes up so the hospital system doesn't really take a deeper discount. It makes it all budget neutral to them." And I found that fascinating. And I've seen it repeated with different carriers. With another of those four, they use the unspecified radiologic procedure code for each modality. And those seem to escape the claims edits and are paid out much higher. So it's a dirty business.
It is. And, the sad thing about it, Dr. Dickerson, is it's dirty, yet it's legal. I mean, our state and federal government have completely made it legal. In fact, they promoted it. I mean, they have created laws to support these kind of entities. And the thing is patients are suffering. That's the worst part.
Absolutely. In each of those settings, that was a tragedy for one of those families. They had a $6,000 maximum out of pocket, and then I think 20% co-insurance above that. I mean, so it was $4,000 deductible and then a 20% co-insurance up to $6,000 maximum out of pocket. So for these, school bus drivers and teachers, that's a financial disaster for those families.
Wow. That's something. So I know one thing in a free market is that there has to be transparency in pricing, right? You can't really truly have a free market if the consumer does not know what they're paying. So I noticed that I went to your website, and you've got different locations and prices of X-ray, CT scan, MRI, and so on. So, and you talked a little bit about your pricing. It has different markets and stuff because it is a free market. So explain. I've went to lots of hospital sites, and I never see prices posted online like that. Will you explain that to me?
Well, it's complicated. It's hard for us to keep up with our database of pricing. We've got about 1,400 centers now, and things change, and they remove this modality. It is almost impossible. So I do sympathize with the hospital systems. But, the problem is, even with this transparency bill, hospitals unbundle things, and then they also make regulations where they require this test to get this test. And there's so many permutations of this, like, I'll give you an example. My husband had a kidney stone at Christmas last year. And so, he went in and they tried to basket the stone and they couldn't. And so then they lasered, they did so there's really no way to predict how much that surgery is going to cost in advance. I'm sympathetic with that. But I will say that this hospital system, so the first time they were unsuccessful getting it out. Second time, new calendar year, new deductible, we have to go back in and do this. And they did say, we estimate this is going to cost this much. And if you'll pay $5,000 in cash right now, we'll take it. And we did.
Wow.
And that was really pretty amazing.
Kudos to that hospital.
Yes.
Although, and I don't want to put you on the spot, and you might not know the answer to this, but when you go to a surgery center like Surgery Center of Oklahoma, and you're probably familiar with the Surgery Center of Oklahoma, correct?
Yeah.
Right. So I've met Dr. Smith. I've toured the center. I think he is, a revolutionary when it comes to free market medicine. So, but if he has ACL repair, XYZ dollars. That is what it is. So how can he do that, but a hospital couldn't? And I get it; it's complicated, but I think they make it more complicated than it really has to be. Just like, for instance, in your facility, I'm sure when somebody comes in with just a simple wrist fracture and you say you're going to charge them $50, some kind of complication came up, but do you charge extra for that?
No, that's a good point. And yeah, it is. But it takes it takes a really good, it's different in an ASC too, because you've got a different risk pool. What they see at Surgery Center of Oklahoma is going to be, non-Medicare patients. They're generally going to be healthy or younger. And you have to just consider that risk. And he has, the other thing it's difficult to control in a surgical setting is the anesthesia. And him being an anesthesiologist, he can control that, whereas it's very difficult to get anesthesiologists to do bundled because it's based on time. They're paid by the payers right now based on time. And so it's really difficult to get a flat fee. Because it's going to be based on the surgeon's skill set, how quickly they get in and out. There's so many variable factors. But, in Texas, Shawn and Patrick Kelly have Texas free market surgery. And they've been able to do it in 2 markets now. They started in Austin, and now they've moved out to the Houston area to Tomball. And, they've been able to replicate. The interesting thing is taking that algorithm and moving it into a second market and being successful. But like Shawn said, he said, it's really the best thing about, the most important factor is having great surgeons, because they do that same procedure all the time. They're in and out quickly. They don't have complications. What that kind of bundled pricing assures is that they're only going to do it with the best surgeons. And, the anesthesiologists are going to trust the surgeons that the time is not going to be longer. And so, it really comes down to that algorithm. It's really a great way to assure quality.
I was going to say, and not only can they be transparent on pricing, but, from what you just said, only the best surgeons can do that. And the best anesthesiologists can do that, which means you're getting better quality at a lower price. I mean, it's amazing, so you mentioned about transparency in pricing and how, there was an order to come through. Trump made an executive order that there's going to be transparency in pricing in January. Is that correct? Do you know correct. The details? Okay, yeah. So now that we don't know where this, where the election is headed, do you think is that going to be rescinded? Is there going to be any teeth behind it? What do you think about transparency in pricing and how it's going to go from a government mandate perspective in the future?
I don't know enough of the details. I know the original mandate had a penalty built in if they didn't do it, and the penalty was so small that it seemed to me the cost of generating those prices, if I were in their shoes, I would probably take the penalty, because it's very difficult to calculate those things. I think either way, I do think that the consumerism, I think any president will continue to drive consumerism in healthcare. And I think the great thing about the movement that you and I are involved in is we're really solving these problems. We're really creating a market that's going to work, and then government, there's no way they can continue what they're doing. And really about 50% of the US budget is for healthcare when you start taking the VA system into consideration, some of the things they don't typically consider in their healthcare spend. And so, it's a huge, in the success of our government, our economics, it would be a great thing for the government to be able to, adopt some things like DPC, like subscription-based healthcare. That would be so much better for seniors. Get into, get out of the big PBMs and get into independent pharmacies and things that are saving people money. There's so many opportunities there to go more local with healthcare and to provide better care at lower cost.
Yeah, and I'm with you. I don't honestly think, I think at least the government is realizing there's a problem, and they recognize that, although they probably have for a while. And I'm not one for government mandates and anything. I think that the consumers, the patients and the doctors are what's going to solve this problem. It's going to come from the bottom up, not the top down. I'm with you on that. So, Dr. Dickerson, what fires you up about what you do?
I love practicing, but what we do right now, it's so much better patient care. There are not all, you need an x-ray, you text us, we send you a voucher, we communicate with the imaging center in the background. They're expecting you. You don't have to fill out all the insurance information. You go get that x-ray, it gets pushed to us. We read the study. If there's something we need to call your doctor about or text your doctor about, we do that. It's so much easier care. And, technology has allowed us really over the last, I would say 3 years to leverage some software that really does 85% of our patients interact with us completely on messaging. And, it's just so much easier than the old way. And I'm able to message with patients if they're concerned about COVID risk, or they're concerned about, should they really be having a breast MRI? Their doctor ordered a 3D mammogram. What would be the different, I'm able to talk to them. And, I wouldn't be able to do that sitting on a phone. There's no way I could do that. But I'm able to look at to help Dr. Cook and I, protocol their exams, make sure they're getting the right exam. It's so much fun to be part of a solution that's making things better and easier for patients and more affordable.
So in the past few months, Shawn and I have been talking to not only just patients, but also providers. And I'm sure there's many questions that have been raised today. So if there is a physician, a provider, or a patient in your area that would like to get a hold of you and your company, how do they access you?
They can text 713-524-9190, our main number. And that's 713-524-9190. And they'll be responded to. That's a great system. Email info@greenimaging.net. And you'll be responded to there as well. We still have an Ask a Doctor, Ask a Radiologist feature on the website. We try to make it as easy as possible for people to get to us. And if you see that little blue telephone, that needs to be improved. That little icon at the bottom of the screen on the right, that will open up a web chat for you as well.
That's awesome. I love it. You're driving prices down, increasing accessibility, and increasing quality. I mean, those are three things that usually in a market that you can't get. You always say, in Econ 101, we can give you price, we can give you quality, and we can give you service. We can give you two of the three. Well, what you're doing, Dr. Dickerson, is you get all of the three, and I love it. That's what's driving this free market in healthcare. I love it so much. I love what you're doing for the free market in healthcare and for patients. So thank you so much for being on our show today. I really appreciate it.
Well, thanks for what you're doing. Getting the news out there is very important, and thanks for having me.
All right. Thank you so much. You've been listening to Health Solutions with Shawn and Janet Needham. Tune in Thursday when we have Dr. Diane Bloom and 3 other guests, and we will be talking about is your healthcare provider properly educated? You don't want to miss this one. So tune in Thursday at our midweek podcast, 8 to 9 a.m. Pacific Standard Time. You've been listening to Health Solutions with Shawn and Janet Needham. Thank you so much.